Kenapa?
Maybe can turn on one or two lights. It's too dark to right.
Yes.
When I visited
Ada kursi dah ke?
medical school, right? The medical students, almost everybody use iPad or any kind of digital device. I think there is a trend nowadays, right? Even the walk round, they use iPad. They got the iPad, then they zoom, and show this is the result, and then zoom out again, then zoom in again. Even the walk round, they use iPad in the Thailand. So iPad is not only for entertainment. For you all, too bad. Okay, shall we start?
Anyways.
So it's very good that you have the initiative to prepare it in a written answer. It will be much easier and more accurate. Oh, sorry.
Sorry, bye. Tidak like code.
Thank you for remind that I need to use microphone. So it's very good that you all have prepared the written one. I think it will be clearer. At least I can see what is written here. We can
Means when?
discuss about it more accurately. So, okay, let's start. Table 1, 2, 3. Okay, any volunteer from the table 1 to read the question, please one. Okay,
Case 1. A 50-year-old man had postmenopausal bleeding with associated full-smelling vaginal discharge for 3-month duration. Colposcopy examination by a gynecologist showed a fungating mass at the cervix. A cervical biopsy was performed. You are provided a photograph of the cervix and a photomicrograph of the cervical mass biopsy.
so 58 years old woman had postmenopausal bleeding. So, what is menopause?
No menstruation after 1 year.
Sorry?
No menstruation after 1 year.
1 year of what?
1 year or
Last menstrual period.
From the last menstrual period.
yeah.
Last normal menstrual period. So then, so after the menopause, okay? So post-menopausal bleeding. So post-menopausal bleeding, is the woman cut her finger then has bleeding, then she is postmenopausal bleeding? Then what bleeding? Vaginal bleeding, okay? So postmenopausal bleeding. Okay, in a 58-year-old. So it's logic, right? 58 years old can be postmenopause, right? So if you have to look at the age of the patients. Okay, associated with foul-smelling vaginal discharge. So at the same time, there is some discharge over the vagina for 3 months duration. Colposcopic. Okay, it's a kind of scope that used to examine the cervix fungating mass. I think they tell you the fungating mass already, then you don't need to discuss. So cycle biopsy was performed. You are fine. Okay. Okay, from table 1, can you answer 1.1? Any volunteer? You can just read. Any volunteer? Yes, thank you. Please read. 1.1.
List the causes of vaginal bleeding. For uterine, it can be menstruation, fibroid, endometritis, endometrial hyperplasia, or dysfunctional uterine bleeding. If it's vaginal, then it could be cancer or ulceration. For ovary, it can be ovarian cyst. Cervical, it can be cervicitis or polyps, or it can be due to trauma or intrauterine devices.
Okay. And anyone has any questions? So in the exam, you can classify the causes for vaginal bleeding as the name. It just means that the appearance of the bleeding or the output or whatever we visualize the bleeding is through the vagina. It doesn't mean that the source is at the vagina. So where is the source coming from? So it will be along the female genital tract. Okay. So for example, you have the uterine. Of course, the uterine here, I think mostly refer to uterine corpus, and the cervical here refer to uterine cervix, because both are actually uterus. One is the body of the uterus, another is the cervix of the uterus. So uterine corpus, we have the menstruation, fibroid, endometritis, endometrial hyperplasia, DUV. Of course, in this practical, you may not need to be more case related, but during your exam, you probably have to be more case related. Okay, so list the causes of vaginal bleeding. So the day I asked, do we need to write list the causes of vaginal bleeding in this patient? They said no need to write in this patient because the students should know is asking about this patient. So you are talking about menstruation, probably is out for your exam, but for practical it's okay. Okay. So uterine cervix, uterine corpus, then that is the most common, and vagina. Okay. Vulva is not part of the vagina, it's the skin. So ovary, you may question, you might wonder how ovary can cause vaginal bleeding. The bleeding is still from the endometrial per se, but it is the hormone. Okay. Some of the ovarian tumor, they secrete a lot of estrogen. Okay. So the hormone induced either the endometrial hyperplasia or endometrial carcinoma or endometrial polyp. So that is the source of the bleeding. So it is an indirect cause. Ovarian tumor will be the primary, leading to some uterine pathology, then leading to bleeding. Trauma, any trauma to the genital tract, intrauterine device, okay, can inside the uterus. So simple, okay. Any questions? Okay, 1.2. Any volunteer from table 1? Okay, thank you. Please.
Describe the gross findings of the cervix. There is a fungating mass. The mass is reddish to yellowish color. There is a central hemorrhage and necrosis, and the size of the mass is about 5 units.
Okay. Okay. So what is this? Okay, good. I had some say is uterine fundus. So it's the body of the uterus, cannot be definitely sure. Probably here is a fundus, but it can be also the anterior surface of the uterus. Okay, so the anexa probably is the anexa is here, but probably can't see the fallopian tube or ovary very well. And this is a view from below the, looking at the cervix from the front, the whole cervix. So there is a, you can say fungating, but you can also say some ulcerating tumor with everted edges. Okay, actually in pathology, right? It's not everything will have definite, be very definite. As long as you say something that we can see as well, then it's okay. And how many things that you need to describe? If the questions ask you, say 2 marks, then you probably have to describe 4. Sometimes it's just half a mark for one answer. Don't answer just 2. If they ask 2 marks, you answer 4. Okay? Sometimes they ask, just give half a mark. Okay? So you 4 things. Most of the time they don't minus mark, even though the things that you is not here. So to try to describe as much as possible. So you can say, okay, ulcer, growth, you can say everted, you can say fungating, and you can say irregular edges. Okay, some hemorrhage. Necrosis actually not that obvious, but you can say necrosis won't be, no people can definitely be sure. Some yellowish area. So necrosis, yellowish area here, right? It can be either pus, most of the time, either pus or necrosis. So it doesn't look like an infection, so it's more likely to be necrosis. But we have to confirm under microscope in real practice. But in case exam, you can just answer there is some area looks hemorrhage, necrosis. Okay. Then since they give you a ruler, okay, you should give a measurement, either a 2-dimension or a maximum dimension. For example, you can see here, it's probably about 5 in the largest dimension. So you just say 5 centimeter in the largest dimension. Of course, you know this cannot be 5 mm, right? Or do you think it's 5 inch?
Inch.
Most of the time we don't use inch. Even though overseas, the inch system in the UK, they don't use inch in their reporting as well. So nobody use inch. So it's either cm or mm. Okay, either cm or mm. So you just describe it in the 50 millimeter in the maximum dimension. Okay, or you want to say 50 times 35 also can centimeter. Then you can say more around the external os. Okay, the tumor grow around the external os. There is no obvious bleeding. So if you cannot think of anything, of course, if you have something that we already said 4 things, irregular edges, growth, ulcer, bleeding, necrosis, then it's already more than 4. Okay. Next, any volunteer? Table 1. Okay, thank you.
Describe the microscopic finding of the cervical biopsy. First, there is squamous cell carcinoma. Second, there is sheet of malignant cells. Then there is large polygonal shape of cell. Then there is large nucleus with prominent nuclei. There is abundant eosinophilic cytoplasm. Where there is well-developed intercellular bridge between the cell of cancer. There is abundance of keratin pearls.
Thank you. Okay, next we have two pictures. Okay, when we describe the microscopic finding, okay, so squamous cell carcinoma is more like a diagnosis by itself. So I don't think they will give you marks if you answer this for exam. Squamous cell carcinoma. The rest is okay. This is all microscopic description. So do not answer this one. I don't think they will give you any marks for this. So let's look at this. Squamous cell carcinoma is quite the simple one. I mean, it's the most important thing that you need to recognize, because any system they can ask you from skin to lungs to genital tract, female genital tract. Probably breast don't have, or of course colon also don't have SCC. It's the most common thing that they like to ask medical students. Okay, so you can start from, I mean, you can be more organized, or you can just describe whatever things that you see. So what I mean by more organized is that you can describe the architecture and the cell later, or you want to describe the cell first, then you look at the architecture later. So for example, in this, right, so in the low magnifications, you probably already can see some keratin pulse formations, okay? Keratin pulse formations is characterized by, it's just like, imagine like pearl formations with a nidus, then with layer of laminated keratin. Keratin actually is a type of protein. It's just like pearl in the something shell. So they are they are ingest some sand, right? Then eventually there is some layer and layer of mineralization, then form into a pearl that ladies like. So it's the same here. So there is some dead cells in the central, then eventually the cells die. Okay, just like the skin, we have an epidermis, we have the keratin that's shed off, right? So this they mature towards the central. So layer and layer of dead cells and laminated into a keratin pulse, right? Okay, here also the same. So you do not see, usually you will see the nucleus become faint and lesser in the central, but you see the viable nucleus at the periphery. So first you see the keratin pulse, you can see very infiltrative because it's present everywhere. Okay, and you see some, most of the time when it's something benign, okay, it's either you can see at the margin, the edge between one flap and the other side don't have any epithelial. But this epithelial clusters is everywhere, and more so is rather irregular, means that they form multiple like tongue-like protrusion. So like here it's supposed to be, if you imagine a benign one, it should be something like this. Okay, something like this. But here there is some protrusion come out, then go in again. Okay, then come out, then form a big clusters, then go in again. So it's rather abnormal. Usually this kind of jagged or irregular extensions is more common seen in carcinoma. Okay. So keratin pulse, irregular edges of the sheets of tumor. Okay, that is very good. Sheets of tumor usually means that there is no hole. Okay, no hole in between the tumor cells. Usually what I mean hole is that there is no lumens. No lumens means that it is not adenocarcinoma. So sheets of cells usually more commonly people describe for, it can also be used for lymphoma, I think, but definitely not the adenocarcinoma. Okay, sheets of tumor cells. Okay, they form sheets. Then, okay, for the architecture wise, you can add extension. Then to the tumor cells, you can start from the nucleus first. Here, the nucleus probably not so clear. You have to see this. Okay, this part is a normal. This is a normal endocervix. Okay, some reactive changes. These are tumor cells. These are tumor cells. If you can see, in the background there is a lot of inflammatory cells. Okay, inflammatory cells, they are more like discohesive, means that they tend to be more like spherical. They don't form cluster. For the tumor cells, because they are epithelial cells, so epithelial cells have cell junction, so they will be very cohesive. The cohesiveness will be retained until very late to the poorly differentiated and it will lost. So you can see the cell, they are like syncytial, means all they are cohesive clusters. So you can start to describe from the nucleus. So you can say hyperchromatic also can, vesicular also can. It's actually no definite wrong and right for that. If you say this one is more hyperchromatic, means more bluish than the normal cells. Then usually sometimes we don't, I won't penalize students, but it's okay if you say want to say hyperchromatic, but in fact it's not that hyperchromatic. You see the nucleus, this one is normal, this one is the tumor, is it more hypochromatic? It's not so obvious. Pleomorphism, you can see some nucleus is smaller, some is larger. Okay, there is some degree of pleomorphism. Compared with here, you can see that this is a benign. You can see that most of the cells, nucleus, they are almost the same. Or here you can see some degree of different. Like here, this one smaller, this one slightly larger, this one even more larger. Okay, so you can see some degree of nucleus pleomorphism. For nucleolus, you have to find. It's not every cells will have that. Okay, but usually squamous cells will have some degree of nucleus. For nucleolus, like over here, this one. You see one blue dot or uric dot, the central of the nucleus. So you have the prominent nucleolus. Then mitosis, this is a mitosis. This one is a mitosis. You can see like the jagged. Okay, so this is mitosis.
Okay, mitosis.
This one is probably also the mitosis because we don't, but it sometimes can be controversial. In real life, we will try to ignore this one, but this one, yes. This one can be a pyknotic cell because the cytoplasm is 2 eosinophilic. So after this, you can describe the cytoplasm. The cytoplasm is not a high NC ratio. The NC ratio is still quite moderate to low because there is a lot of cytoplasm. So you can say a moderate to abundant cytoplasm and eosinophilic eating color. The NC ratio is not high, or you can say NC ratio is low. NC ratio is nucleus to cytoplasmic ratio. In a tumor, you in an adenocarcinoma, you expect a very high NC ratio. But in a squamous cell carcinoma, usually the NC ratio will be low because they tend to have a lot of cytoplasm, even though in moderate differentiated squamous cell carcinoma. Intercellular breaches actually is not that obvious. Okay. To say this is a squamous cell carcinoma, keratin pose is the most distinctive one. If you have keratin pose, nobody will argue with you. You can definitely say it is a squamous cell carcinoma. But in here, then you will have difficulty without the first picture to say it is a squamous cell or not. Okay. So the second most distinctive one is the intercellular breaches, but it's not obvious here actually. I wouldn't say there is a definite intercellular features. So the third one is the individual cell keratinization, where you see a very eosinophilic color cells, okay? But it's also not that obvious actually, individual cell keratinization. So then you don't have, if just this picture alone, you don't have a definite features to say it is a squamous cell carcinoma. But there are some features that suggest it. For example, the low NC ratio, the coherent nucleus in some of the cells, the polygonal tend to be polygonal appearance of the cell membrane. You can see that they are just like the normal skin, okay? Skin tissue, the nucleus is tend to be more at the central of the cells. The nucleus, they tend to be in the central rather than they polarize to one end. These are glands, they usually tend to polarize to one end, or they have this elongated appearance. And this one is a gland, the nucleus at the bottom, but the cytoplasm at the top. Or squamous cells, they tend to have the nucleus at the central, okay? And another is the polygonal appearance. You can see that the cell membrane, right, they are very sharp at some of the area, okay? And the shape is like a pavement, like a jigsaw puzzle kind of appearance, the cell membrane. So there is some clue, the polygonal shape, low NC ratio, eosinophilic cytoplasm. So those are the clues that suggest this can be a squamous cell carcinoma. Okay. Any question? Okay, hope you are clear. So you can also, if you don't have anything in your mind, you can also describe the background a lot of lymphocytes. Probably it's even more difficult if you can recognize it. And background has more lymphocytes. Some people even say this is a desmoplastic reaction. The carcinoma can tend to cause fibrosis around the area. They call desmoplastic reaction. Like in here, they look like synthetic or desmoplastic reaction. There is a lot of lymphocyte and plasma cells in the background. So you can be systematic during the exam. Okay, next. Any volunteer? Still paper one? Okay, thank you.
State your diagnosis and list the viruses strongly related to this condition. So our diagnosis will be cervical cancer, which is squamous cell carcinoma. And the virus strongly related is human papillomavirus (HPV). And there are two types which are high risk and low risk. For high risk, there will be more common 16 and 18, and 31, 33, 35, 39, 45, 51, 52, 56, 58, 59, and 68. And low risk type will be 6, 11, 42, and 44.
Thank you. Okay, when you have a diagnosis, right, you always ask yourself, is this enough? Or either you go to be more detailed or you go to be less detailed. Okay? So for example, looking at this, okay, and all these pictures all together, cervical cancer, is it detailed enough? Okay. This picture you say cervical cancer, yes, enough, but you have this already. Should you still say cervical cancer only? If you like this, then you don't know it's cervical adenocarcinoma or cervical squamous cell carcinoma, then it's okay. Or is it in situ or just invasive already? You don't know. But you have this, then you know, okay, this is squamous cell carcinoma. So is this in situ squamous cell carcinoma or invasive squamous cell carcinoma? Invasive, okay. Then you can answer. So can you go for more? So every time you have an answer ready, then you just ask yourself, can we tell more about it? Okay. Of course, at your level, you tell more is like stop at the invasive squamous cell carcinoma, but in pathologists, then we have to say it is a well-differentiated invasive squamous cell carcinoma of the cervix. Because the tissue organ also is part of the diagnosis. If I over the phone, the patient is diagnosed with squamous cell carcinoma. Do you know what is that? You don't know, right? invasive squamous cell carcinoma of the cervix. Okay, this patient is diagnosed of invasive squamous cells of the lung. This patient has invasive squamous cell carcinoma of the skin. So they are treated differently. It's not the same disease. Okay, so you have to mention the organ as well. So this is invasive squamous cell carcinoma of the cervix, well differentiated. Okay. So is the virus strongly related to this condition? Okay, human papilloma virus. Okay, very good. High risk and low risk. So if you ask me, if you can remember the first two, 16 and 18. That is the most important one. If you want to know more, then the first five, 16, 18, 31, 33, 35. Okay. Next, any volunteer? People want? Okay.
1.5 lists the predisposing factors of this condition: presence of cancer-associated human papilloma virus, persistent detection of high-risk HPV, smoking, immunosuppressed, such as in organ transplants, HIV infection or drugs, long-term use of contraceptive pills, multiple sexual partners, family history, multi-parity, early age of first sexual intercourse, uncircumcised sexual partner, and genital infections such as chlamydia.
Thank you. Okay, so any question for case one? Okay, now table two. Volunteer, please read the question. Okay. Okay.
Is to a 30-year-old woman started over at on the 10th of month this month with an allegation that is right certain breast. Abdominal ultrasound reveals a circumscribed, solitary, mostly cystic right ovarian mass. Ovary is its size. You are provided with a photograph of 3 photomantograms of the right ovary.
Thank you. So young adult, female, lower abdominal pain for the last 6 months. Okay. Of course, you should know what are the organs in the lower abdominal. Okay. So like bladder, female genital tract, and the lower GI, gastrointestinal tract. Okay, that is the most common one. Then there is a right annexal mass. Annexal here, it means that annexal also means accessory. So in the female, usually they refer to fallopian tube or ovary, and they form a mass. Okay, forming a mass doesn't mean definitely neoplastic. Some kind inflammatory lesion also can form a mass. For example, tubeo-ovarian abscess, they can form a mass as well. So okay, now we look further. Abdominal ultrasound reveal a circumscribed solitary. Solitary means single. Mostly cystic right ovarian mass. Okay. So that is the good part about ultrasound. The most important thing that they're able to see is this a fluid or non-fluid. Okay. That's why cystic is very good to see under the ultrasound. Yes, cystic or the ovary is size. Okay, so can we have anyone to volunteer answer? Yes. Okay.
So this is the photograph provided. First, you need a cyst containing hard, good and sebaceous material in the ovary. The surface of the ovary is shiny, indicates there is fluid, yellow whitish mass, and then shiny size of fluid filled cyst with 2 to 3 centimeter in length. Hair buried epidermal lining, nodular projection, which deep contracting.
Mature dengan mature dengan yang ini macam mature silap.
Okay, thank you. Very good. Okay, so there is no ruler here. If there is a ruler here, you can say the unilocular Unilocular means uni means locule. Locule means like a room or like a space. So unilocular because you don't see multiple septa or divide into multiple room. So unilocular cyst. Okay. Some of it a bit solid area here. Some here. A bit nodular in the inner surface. So if you have a ruler, then you can give a measurement measuring 10 centimeter. I think should have the measurement here. So measuring maybe not 10 or maybe just 4 or 5 centimeter times 3 centimeter. Then you give the wall measurement. Any cyst, you try to describe the cyst wall. So for example, here is the cyst wall measure 1 millimeter to here is the thickest part, 5 millimeter or 10 millimeter. Okay, so the cyst wall thickness measure 1 millimeter to 10 millimeter in thickness. Okay, so from outside you describe to inside. So this is a unilocular cyst measuring blah 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 and blah blah blah. The cyst wall is blah blah blah. So what is the if you don't find anything else on the surface, but you can't see here. So if you like sign perforation upper, then you can describe. Other than you look into the content, okay, from outside to inside. Look in the content, so you see some hair. Epidermis or non-epidermis, sometimes yes, you guess it looks whitish, right? So it should be some epidermis. This maybe is a teeth. Okay, or this is the teeth, but I think this is not because got hair come up. So maybe this is the teeth that you all say. So this is probably the epidermis that you all refer to. This is a hair definitely everyone can recognize.
Appreciate.
So the yellowish material here is probably some sebaceous material. There is some keratin material that is degenerated. Then you can see the surface, the inner surface is glistening. Regarding the fluid part, shiny size fluid fuses, because we don't see the fluid. And but of course this must be some fluid lah. If not, it cannot be just vacuum, right? Or air, because our body don't contain air except lung or colon or GI tract or stomach. So it shouldn't be air, so it should be some fluid. But you can say it's a glistening surface rather than shiny. Okay. Okay. Next, 2.2.
Describe the photomicrobial multiple differentiated tissues of nature cystosperma, presence of chondrocytes, cartilage, contains skin appendageal structures such as hair follicles, sweat glands, sebaceous glands, and linings of simple squamous keratinized epithelium, presence of smooth muscle cells.
Okay, thank you. Describe the photomicrograph provided. So let's look at them. Okay, so first you want to get the diagnosis. So for this you can definitely make the diagnosis. So this is cartilage. Can recognize cartilage? So cartilage, the characteristic is you see they are very blue in color, and this blue in color actually is the matrix. They are not nucleus. It's a matrix. It's a background glycose aminoglycans, the background stroma. Okay, then you have this called lacune in leg. So multiple holes, whitish one, they are called lacunes. So they are legs, and there are some very pygnotic small dot nucleus. Actually, they are the nucleus of the chondrocytes. So this is a very characteristic of the cartilage. Okay, so you must able to recognize it because it's very characteristic. Even low magnification, you can be sure
Blue
that
means
it's a cartilage.
matrix.
So
Blue color
cartilage arises from
matrix.
germ cell layer. You have how many germ cell layers? Cartilage arise from mesoderm. So this is the sebaceous. This looks not sebaceous. This looks like seromucinous gland. Looks like seromucinous gland. The mucinous is the whitish color. Because the nucleus, you don't see any nucleus in the central line because the nucleus all pushed to the bottom. So this is a serous. This is a mucinous gland. If this is a serous gland can be very pale as well, but the nucleus is at the central, so they don't get pushed to the periphery. So this is a mucinous gland, and this is a serous part. So seromucinous glands. And what is this component here? Anyone? What is this? Fat, yes, adipocytes. Histology we don't call fat, we call adipocyte. Adipocyte means fat cells. This one will be different. Nerve. This is a nerve bundle. This is a gland. Okay? You have a lumen. This structure has a lumen. So you always see the same thing. The well-defined glands are lumen, cytoplasm, or cytoplasmic membrane with any special differentiation. Like here, it looks like a cilia. Okay, so lumen, cytoplasm, then nucleus, then the stroma at the periphery. So it's very easy to recognize a gland. Okay, this is something that you must know. So glands is from which germ cell layer? Usually ectoderm, endoderm, mesoderm. Endoderm. Okay, endoderm. Usually is endoderm. So fat cells, adipocytes. Mesoderm, connective tissue, mesenchymal cells, or mostly from mesoderm. Okay, now let's look at this. Okay, you can see this is a squamous epithelium. Just like a normal skin, they have the basal layer, and they become more mature, more low NC ratio, and become keratinized, and you have the shedding of the squams or the keratin. So this is a squamous cells. So squamous cell is from ectoderm, and this is the appearance of sebaceous glands. You can see that in the low, right, from far away here. One Chinese word. Okay, so from this magnification, so from this magnification, you can see that the cytoplasm looks clear, right? Just like this one, but the nucleus is at the central. You see, the nucleus is at the central. So this is a sebaceous gland. This is a sebaceous gland. Just now that one is a mucinous gland. So this is a sebaceous gland. So this is the ectoderm of it. Okay, this is another picture showing some squamous epithelium here, some fat cells or adipocytes here, some seromucinous glands here. Okay, so this is a hair follicle. This is how the hair follicle looks like under the microscope. Okay, this is the hair follicles. And you can see that the hair actually growing from, go through here. This is the most bottom part of the hair follicles, the dermal papillae, and the hair bulb. And then they grow and eventually mature and form a hair. So we have this one you all can hear. This one.
Looks like adipocyte,
What is this? This structure?
but it doesn't look like adipocyte at the same time.
What is this? usually characteristic of thyroid follicles. The characteristic of thyroid follicles, one is, you see they are fluid containing like a gland, but it's actually very dilated. Okay, very dilated kind of gland. So, and at the background you can see a lot of very bright pinkish, reddish color. Those are because a lot of blood. So there is a characteristic because endocrine glands, they usually have to secrete the hormone into the circulation, right? So the colloid here, the thyroid colloid, will secrete into the blood circulation, so usually tend to be very hemorrhagic. So this pinkish amorphous color is very characteristic for colloid. Sometimes you can have a cracking. This is probably a bit like more like pale area. Sometimes you have a more definite cracking in the colloid. So these are pictures of thyroid follicles. So thyroid follicle is from the endoderm. So of this, all these features, right? Okay, you see any immature cells? No, you don't see any immature cells. So immature cells means that those cells that may or may not look like normal cells, but they usually have an immature appearance where the nucleus is usually very large. Like they are proliferating still, and the NC ratio is usually very high because they are not differentiated yet. And those are the immature component of the teratoma. If you have that, then you have to diagnose another disease. Okay? If not, all these are mature cells only. So what is the diagnosis? Okay, next. Volunteer. Any guy from the second table? Always female. Always lady. Any guy want to volunteer to answer? Slow. Next. Mature cystic teratoma. Good. Okay. So first, is this a teratoma? Yes. So why is it a teratoma?
Ada hair.
Yes.
Tiba dia.
More than 2 germ cell layer. Okay. We give if you remember, I think year 1 we have the lecture on the tumor nomenclature. The tumor nomenclature is based on what the cells differentiated into most of the time. That is the main thing that to determine the name. So most of tumor cells, right, they differentiate into one type of cells. Like squamous cells, then you call it squamous cell carcinoma. If it is glandular cells, then you call it adenocarcinoma. Like this, they differentiate into multiple different kinds of cells. And not only that, they differentiate into multiple germ line, different germ cell layer. So that's why the teratoma. So 2 or more germ cell layer tissue, then you will say a teratoma. Is there immature cells? No, there is no immature cells, so you will be a mature teratoma. Okay. So this is only solid or they are mostly cystic. So people will tend to call this a mature cystic teratoma because it's mostly cyst. But in the exam, I don't think they will penalize you if you miss the cyst. You can just say mature teratoma. Okay. What is this? Okay, next. Okay, next give chance to the guy.
What is the histological origin is in this ovarian neoplasm? Ectoderm, mesoderm, endoderm.
But the fault, I think you clapped too early already. Because the answer is germ cell. For this one, I probably a bit not so clear. Histological origin. What is the germ cell layer origin in this ovarian neoplasm? Then it will be very clear it's a germ cell tumor, right? So they ask histological origin. Okay, I give, if me, I will still give you mark if you give ectoderm, mesoderm, endoderm. So this is a germ cell tumor of the female ovary. Okay. Okay. Next, anybody, male, guy or boy, guy or girl. Anyone volunteer? Next. This one is correct. Can read just a bit. Okay, very good. Thank you. Any questions for case 2? No. Okay, let's go to the case 3. Okay, any volunteer? Table 3. Okay, please read.
So, a 28-year-old female presented with surgery at the wedding at the emergency department. She has been in a very for the past 2 months. On examination, there is marked evidence of over the suprapubic area. The hysterectomy was performed at right salpingrectomy. You are provided with a photograph of the hysterectomy specimens.
Okay, thank you. So, 28 years old, very young huh? Not as young as you all. Acute abdominal pain. So, last time a surgeon, right, he make a joke. Acute abdomen means the abdomen is cute. So you have a cute abdomen. Okay, so but it's not the same. This acute abdomen means the pain is very short duration. It's not the abdomen is cute in appearance. Okay, acute abdominal pain. So she has been amenorrheic for the past 2 months. So if like this, can it fit to your definition just now? Is menopause already? So you have to find what is the definition of the menopause. So is it menopause? No menstrual period for more than 1 year, or this is not more than 1 year, it is 2 months. Sorry guys. Already. Okay. On examination there is marked tenderness over the suprapubic area. You know what is tenderness, right?
Masalahnya macam mana
What is tenderness? Sorry. So what is different from pain?
Kan banyak benda boleh. Tak contoh bukannya kalau
Pain
dia tak
is a
implant dia
symptom
generate.
patient tell you. Pain. Tender is a sign. When you see the patient face, you press the face that she pain, and then she looks pain, then you say tender at the area. So it's a sign, okay?
Umur dia 15 tahun ke macam.
Right salpingectomy, okay, long swelling salpingectomy was done. Removal of the fallopian tube. Laparotomy means the open surgery, looking at usually the abdomen, looking at the whole abdominal organ, including the pelvis. Okay, so fertile age lady with an acute abdomen, and she has no menses for 2 months. So what is the differential diagnosis? Okay, you can think about it. So let's go to the photograph. History, yes. Volunteer history. And 3.1.
Three times.
good. Very good. So this is a fallopian tube. Okay. There is a two fetus. Is it fetus, right? Or twins some more. Okay. Two embryo. Okay. Two embryo at the fallopian tube. There is a, you can see perforation, you can see rupture. Okay, so what is it? Rupture. Okay. Due to blood clot formation. Is it ruptured due to blood clot formation? Or the rupture also caused the blood clot formation?
Blood clot.
Blood clot was a rupture.
Cause blood clot.
Rupture due to blood clot, if you imagine, is like they bleed too much already until the blood accumulate and burst the fallopian tube.
No.
Or is it due to the embryo tissue?
Embryo tissue.
They destroy the muscles. At the same time, they destroy the blood vessels. So that's why the bleeding occur and the muscle wall is perforated because it's weakened.
The second one.
I think I prefer to the second hypothesis, and that is usual. Not really because the blood clot explode the fallopian tube. So you can, okay. So from external to internal, you can say. If you cannot recognize what it is, then based on the history, this should be a fallopian tube, right? Okay. They say this is a part of the fallopian tube because a complete fallopian tube should have a fimbria. But doesn't look like a fimbria. So you can say part of the fallopian tube measure 5 centimeter in length, about 5 centimeter in length, and you can give this should be the diameter. This is the diameter. So 1.5 centimeter diameter to 2 centimeter or 2.5 centimeter diameter. So this is a fallopian tube measuring 5 centimeter in length. 1.5 to 2.5 centimeter in diameter, show presence of the two embryo at the surface of the fallopian tube. You can say facing each other. Then there is a perforation, okay, or rupture of the fallopian tube at one side. So the left side is a bit. Usually we don't say. It's okay, you can use this during the exam, not wrong, but in the real life you don't say like this because you don't know the thing can flip right. And this is not definitely the left side in relation to the patient because we use that terminology for the anatomical position of the patient, left or right, up or down. You can say left side of the photograph. The left side of the photograph, but not the left side of the fallopian tube. So there is a rupture containing blood clot. Okay. So okay. So next. Yes. Thank you. Okay. Very good. So pregnancy, sure pregnancy?
Yeah.
Yes, because there is an embryo, right? So it's definitely pregnancy. So tubal, sure, tubal?
Yes.
Sure, because it's in the fallopian tube, right? So how about ectopic? What is meant by ectopic here? Outside of the endometrium. Okay. Outside of the endometrium. Even in the myometrium is still not considered normal. In the cervix is still in the cervix also is considered ectopic. So ectopic means that it's out from the supposed location. So the supposed location should be in the endometrium only. So if it is in the uterine cervix, it's an ectopic pregnancy. So the complete diagnosis will be ectopic tubal pregnancy. But if you want to say tubal pregnancy, it's okay. If you want to add more, can you tell more? You can say ruptured tubal pregnancy. Okay. And that will probably more explain on the clinical symptoms because it's ruptured. That's why the patient has pain. If it is not ruptured, the patient may not have any symptoms. Okay. 3.3. Okay, now keep the chance. Any guidance at that table? Okay, please try.
JJ. Edit. Yes, Miss Bondan.
Okay. Okay, nothing. Thank you. Next.
Sorry. Masih dah boleh.
Oh, you haven't finished. You want to reach complete?
Pukul berapa kau cakap tadi dekat dalam grup? Jumpa tak silap. Pendek. Yang ni hantar bagi dia.
I think it's okay. I think no need to write this one. You just remember.
No. Tak tadi. Anak ni. Nabi.
Shoulder pain is because because this thing is ruptured, so blood come out from the fallopian tube. So blood actually is emitted. For example, in the peritoneal cavity, do we have blood inside? What do we have inside the peritoneal cavity?
Fluid.
Just fluid, peritoneal fluid. Usually is just very minimal product inside, no cells, nothing. So if there is a bleeding, the blood itself can be a chemical intern to the diaphragm surface. That's why the patients can have a deferred pain because the diaphragmatic surface, some of the sensory nerve actually is referred to the phrenic nerve. Okay, it referred to the shoulder area. That's why the peritoneal irritations can sometimes cause the shoulder pain because of the phrenic nerve. Next, volunteer, table 3. Anyone? Okay, thank you.
Kentut. Ada poket kat tepi eh? Oh, tepi ada. Tak ada. Alah, aku ada duit lah yang 390. Dah takut. Macam ni. Apa dia? Macam ni. Tak thinking, tak boleh cakap. Takut. Boleh jadi?
Thank you. Okay. Any questions? Okay, next, 3.5. 3.5. Okay, thank you. Okay, any questions for case 3? Very good. 4. Back to here. Table 1, phase 4. Any volunteer? Okay, thank you.
50-year-old male presented with urinary intermittency, urgency, and terminal dribbling with nocturia. A urethral catheter was inserted to relieve the obstructive symptoms. Per rectal examination revealed an enlarged prostate with smooth surface. PSA was 4.12 nanogram per milliliter. So you're provided with photograph of normal and patient's prostate, and a normal and photograph from normal C and patient's prostate D.
Thank you. 50-year-old male, urinary intermittency. What is urinary intermittency? I also not sure. You have to check what is intermittency.
Kencing tak
So urgency, what is urgency?
kencing
Tak rasa nak kencing.
Intermittency.
What is urgency?
Urgency macam
Rasa nak kencing.
Boleh tahan. Yes, cannot tahan because in these conditions it's called lower urinary tract symptoms, LUTS, LUTS. The reason for urgency is because imagine kamu ada pipe suara sumbat, apa berlaku? Pipe dia sumbat kan, dia if you have a tank of water, not the pipe from the normal water source, it's right at the pipe from a tank of water. So if you open, then you have to wait for some time only the water come out. And so there is hesitancy. Just like a guy go to the toilet, they have to stand very long, then only the urine come out. So there is hesitancy. So you open the pipe already, then you wait, then only the water start to come out. Then after the water come out, the stream is very weak. So because it's already obstructed, again the pipe is obstructed. So the stream is very weak. So when the stream is very weak, towards the end, right, the tank cannot empty completely, right? Because the pressure becomes lesser. So the water becomes lesser, then until certain level, the water cannot completely empty out and always have some residual. And that is the reason why they have urgency and always need to go washroom because they cannot completely empty the urinary bladder. And towards the end of the urination, there will be terminal drilling, just like the water pipe is obstructed. So dia akan tunggu lama baru dia mula start ada air keluar. And the air keluar also very weak stream. Then towards the end, and even though the tank is still have water, they will start to drip on it. Drop, 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 drop. That is terminal dripping. Okay. So sometimes they synonymous, the neurosurgeon is like a plumber. So solving the problem. So they always like to synonymous different occupation, like surgeon is like a butcher, then neurosurgeon is like a plumber.
It looks like
Okay, so and urethral catheter was inserted to relieve the obstruction symptoms. Okay, because urinary tract obstruction can be very suffering. We will enlarge prostate. So for rectal examinations. So you have to know in front of the rectum what are the structures. So in front of the rectum, for guy, male, the structure is prostate. Okay, and above it is a urinary bladder. From female, in front of the rectum is the
uterus.
Out of darkness and then the uterus. Okay? So you can say uterus. ESS was 4.12 nanogram per mil. In exam we will give you the normal range. So this is just still acceptable, borderline high. So this is the normal for comparison. This is the normal one. Okay, so anyone want to describe 4.1?
This patient is prostates.
So table volunteer.
Describe the microscopic features seen in the photography. So we could appreciate an enlarged prostate with multinodular surface around the prostatic urethra. We could also see pinkish bright in color and a smooth and a shiny surface. And the patient prostate 5 centimeter in diameter and a normal prostate 4 centimeter.
What 4 centimeter?
Normal 4 centimeter.
Oh, normal, this one.
Ah.
Okay, thank you. So if they say describe in photography, you just describe a bit. It's okay. So this is just for learning purposes. So let's look at this. Okay, so this prostate, they cut into section horizontally. Supposed to be. So this is about 5.5 or 5 centimeters times 5.5 or 5 centimeters. You can give a two dimension. Then you can see a nodule. Okay, so that's why your friend has described correctly multiple nodules or nodular surface involving both right and left part of the prostate. You don't know which part is right and left, right? But you say both is involved there. So both right and left. Nobody will argue for that. So both and right and left processes are involved by the nodular formations. The nodules look circumscribed, and you can say grayish, pink, yellowish in color. This is a urethra at the central that looks slit-like appearance. Okay. While the glistening actually, because this is at the, I don't think it's not that important actually, the glistening, because this part is actually the cut surface. It's not the original one. So this can be due to the architecture or whatever. Okay, so no need to describe this glistening part. If it is on the surface, like if you say, okay, this mucosa is glistening, then it's okay. Or you want to say, like the ovarian cyst, you want to say this surface is glistening, is okay, but you don't need to describe here is glistening. Usually it's not that meaningful. Okay, not that meaningful. Okay, so next. Okay, so yes, thank you.
State microscopic features of micrography. So what we can use is that there is
Macam lain je dia punya prostate punya.
present. There's an increase in the nucleus to cytoplasmic ratio, increase in the mitosis, which can be seen through the stromal proliferation, increase in the
Nak sikit boleh. Sikit.
sorry, formation of well-demarcated nodules, increase in mitosis, hyperplastic glands lined by inner secretory and outer basal cells.
Okay, thank you.
Kita kena dekat frontier. Suara dia tak boleh. Longgar.
Let's look at the photo. So is this gland? Yes, this is gland. So this is called what?
Prostate gland.
Yes, lumen. So this part? Cytoplasm. Okay. Cytoplasm. This one? This row of blue color dot.
Nucleus.
Yeah, so you can see that they have these 3 layers. Okay. Lumen, cytoplasm, then nucleus. Okay, mostly at basal. Some is a bit higher. But they just look at this. Do you think there is 1 layer or 2 layer or more than 2 layer of nucleus?
More than two. More than one.
More than 1. This one you can see, right?
Yes.
They are all aligned at the base. So this is a basal cell in the prostate. You can see this basal cell all aligned at the base. So this is the second layer. This is called the luminal cell or the secretory cell. Okay, secretory cell. Inner cell. Inner. So this is a secretory cell. This is a basal cell. So whenever you see this basal cell and secretory cell, it usually means benign, because malignant can only have one layer, okay, of cells. They do not have two different type of cells. Or I should actually refine and say malignant, they can only have one type of cell. Okay, they can be multiple cells, multiple layer, but they only have one type of cells. They don't have two types, secretory and the basal cells. So actually they just want you to answer that. Okay, so look at this photo again. So this is a lumen. Okay, this is a surface the cytoplasm of it. Okay, and the nucleus. And the nucleus have two layers. It probably is not so obvious here compared to here. The nucleus has two layers as well, and all these cells. So basal and luminal, so gland formation. So these look like benign. Okay. Okay. So next, maybe you give time to the table too. Okay. Yeah. Okay, good, thank you. Or you can say nodular hyperplasia, okay? Because nodular appearance, right? So benign nodular hyperplasia. Okay, next. Volunteer, table 2. Any volunteer? I think the thing here I probably want to convey is that, is this called benign prostatic hyperplasia? Why not we call it benign epithelial hyperplasia? Can we call it benign epithelial hyperplasia? Why not? Say it's stroma proliferation as well. Yes, good. So in these lesions, you don't see just the increase in terms of the epithelial gland, but actually the background stroma is increased as well. Okay, the background stroma is increased as well. So the parenchyma is not only supporting for the epithelial, but they themselves actually respond to the hormone. Then that's why usually this kind of condition we call it nodular hyperplasia or benign prostatic hyperplasia. It's same like the colon polyp. We call it colon polyp, or call it hyperplastic polyp. We don't call it epithelial polyp. Okay, we don't call it epithelial polyp. We call hyperplastic polyp because there is an increase in the stroma and also epithelial cell. Okay, next. Table 2 as well. Any volunteer? Guy? Any more guy want to?
State one complication of the condition. So the first one
So complications. Dysuria is what it means by what is the meaning of dysuria?
Difficult with the urinary.
Pain in the urine. So usually when we say complication is a condition or disease itself. Okay. So dysuria is more like a symptoms. A patient complains to you, I have pain when I urine, when I pass urine, then there is dysuria. So it's not really a complication. Complication is a condition. Like if you say this condition can lead to cancer, then there is a complication. Or this condition can lead to stones formations, that is a complication. So it can lead to urinary tract infections. So how can it lead to a urinary tract infection? Like I said, the water cannot completely pass out, so a lot of urine retain in the bladder, so it tends to get infections. Because one of the defense mechanism of urinary system to prevent infection is the continuous let the water to flow out, and the cells will shed as well. Okay, the urinary cells, urothelial cells will shed as well. So the bacteria cannot grow, cannot retain. So if there is an obstruction, the urine get retained, always retained, so there will be higher chance of infection. And not only infection, another thing that you can imagine is that the urine probably also retains some amount of stasis, and another is the concentration, and you will lead to stones formation. So urinary bladder stones is another condition that can lead to this complication. Last, case 5, still table 2.
Case 5, a 45-year-old lady presented with a hard mass in her left breast of 3 months duration. The mass was progressively increasing in size, and 1 month later, she had noted another lump in her left axilla. The biopsy was performed on her left breast lump.
That's a good investment.
He subsequently underwent a left hysterectomy with axillary clearance. So for our first question, describe the microscopic features of the spectrum specimen.
No,
So
I'm boy.
there's a grey whitish
Bottom.
part and
The leg.
also solid grey white
Betul.
mass with
And the
irregular intrusive
selain
adjacent normal breast parenchyma.
Okay, 45-year-old lady, heart mass, left breast 3 months, increasing size, lump in the left
Breast
axilla. Why is
cancer,
lump in the
but
axilla? Like this kind of condition. Lymph node enlargement due to about the metastasis. CVD is malignant. Okay. Carcinoma left breast lump, no, abnormal. So left mastectomy, removal of the breast, and axillary clearance. What they clear from the axilla?
Lymph node.
Huh?
The lymph node.
Lymph nodes, yes. Okay. So they take out the lymph nodes. Okay. Solid. So this is a breast tissue. You can give a measurement of the breast tissue. Since they tell you it's breast, they won't tell lies. So this section from the breast tissue
Thank you so much.
90 or 9 centimeter times 4 centimeter, focally covered by unremarkable skin. So this you can see this skin. So within the breast tissue, so there is a presence of a grayish mass measuring 3.5 times 2.5 centimeter. The edge is irregular. Okay, you can see that you cannot define the border very well. So where is the border? So when I say irregular, you can say that this is not a rounded structure, right? It's not a rounded. So this is not a smooth, regular one. So it's irregular. So another is that find where is the margins. So you may follow some part is a bit sharp, like here it looks very sharp between the normal yellowish to the tumor and normal one. But some you don't see the distinction very well, where is the border. Okay, so they are very infiltrative or very poor margins. Okay, poor margins between normal or abnormal. In some amount maybe there is a yellowish here. This one is more likely to be a necrosis. Okay, you see some necrosis, which is quite common in the breast cancer. So this grayish color is the whole thing is the tumor. From here to here. So no obvious hemorrhage here. The surrounding breast tissue appear unremarkable. Okay. And the tumor does not involve the skin. Doesn't look like ulcerated the skin. Okay. Next. Table 2 still. 5.2. Thank you. So, okay, so tubular formations, but not many. Yeah, okay, then. So the architectures usually you can describe irregular cluster, means that they are, this is cohesive. The cells look they stick to each other, but that's why we call it clusters. But the clusters is rather irregular because they have different shape and size. So irregular clusters. Okay, some they form like a cords, means like one row of cells. Okay, irregular cluster and cords of the tumor cells. Okay, and that will probably the only architecture that you can see. Then we start with the nucleus. So the most distinct features here, the nucleus from nucleolus is very prominent. You can see like here, almost all the cells will have prominent nucleolus. The nucleus itself, per se, it doesn't look very distinctly hyperchromatic actually. You see the pale color rather than dark blue color. This is a pigmented cell. So you can say the nucleus chromatin looks vesicular. Sometimes we use that term, vesicular, V-E-S-I-C-U-L-A, vesicular, vesicular chromatin. The cytoplasm is moderate, okay, moderate amount. The presence a bit eosinophilic, and mitosis is not that obvious, but pigmented cells is here and there. So NC ratio is actually not that high, probably just moderate amount. So 5.3. Last one, last table. 5.3.
Mana? Bening. Bening ke? Bening.
Okay, good, thank you. So E is malignant. The reason is from the, you have to point out the malignant cause. Common features are heart, okay, progressive increasing, means it's something that is, at least it's not reversing, and she have an axillary mass, okay. So the features here to point to malignancy is irregular edges, okay, irregular solid mass. And the features here to say malignancy is the infiltrative edge, prominent nucleolus, and no tubule formations. So those are the features to say this is American. Okay. Any volunteer? 5.4.
Ada tak sah?
Okay.
Baik-baik. Kalau anjing. Itu kami balik cuaca. Cuaca lah aku suka tahu. Ya kan? Pun tak.
Thank you. So, investigation. So, investigations, basically they are talking about some laboratory investigation. Imaging is an investigation. Some procedure with some laboratory test is an investigation. But clinical examination is not really an investigation. Okay? Mammography correct, ultrasound correct, MRI correct, DNA PET core biopsy correct. Except the first one is not an investigation. Okay, good. Okay, 5.5.
What is your diagnosis? Invasive vaginal carcinoma.
Okay. Okay, good. Invasive carcinoma of the breast. Invasive breast carcinoma.
5.6.
5.6. He is rushing to go back already. But
Cucu tak ada rumput. Dia 5.7. Dia 5.7. Tadi tiba-tiba 5.7. Aku tak ditengah. Oh shit. Kau nak kau ini? Sinci. Sampai 4 tulis tadi. Sinci. Adalah tu jawapan. Apa salah jawapan? Itu dulu. Kadang aku tak tahu lepas mana. Aku cabut. Tahu tak pada dia. Ada kau tulis aku. Aku kumpul lagi banyak kat sana. Kucing punya. Saya Dr. Colin ni. Colin ni. Colin lagi. Dr. Colin. Colin lagi. Tadi kata kata apa? Colin lah saya kata kata ni. Tahu tak? Colin lagi. Colin lagi aku punya. Apa dia? Energy. Tak nak. Tadi dia yang kata nak.
not fair, right? You read 3 words on me. You read 300 words. So the one that they want, the answer probably is not that bad, but I just tell you the one that they want is this one. The one that I have here. Okay. So any family history and the genetic mutation. Okay. 5.7. Volunteer. Do you know what is the terminology, the nomenclature, the name of the grading? What is it? What is the name of the grading for breast cancer? I think that is the one that they actually want you to write. They always like to ask they like to ask the from Richardson grading. Okay, you must remember. Only a few grading systems you probably need to know the name. From Richardson for the breast cancer, prostate cancer, recent score of recent breakthrough of recent grading. Okay. Other system, I don't think they have a name. Probably fecal grading for the uterine or endometrial carcinoma. Liver, no need to remember that. Because the other grading just the usual, well differentiated, moderate differentiated, poorly differentiated. Okay. 5.8.
The group rejection ready system.
Last one already. Hero.
So the state 1 staging system used in this condition, please elaborate. So basically the staging system is to analyze the extent of the tumor spread. So we use the TNM system. T stands for tumor, where we evaluate the size of the primary tumor. Note for any involvement of the regional lymph nodes, and metastasis for degree of spread from the origin site.
Okay, can you elaborate more? Degree of spread from the original site.
Primary site.
To where?
To other parts of the body.
To other parts of the body. Okay. Okay, usually it's systemic organs, and you can say systemic organs because that is more common. Other parts of body means that it go to the let's say thumb, so it's probably go to the bone, or go to the soft tissue metastasis or skin metastasis. That's what we call. So we usually name it by the organ system, not by the anatomical location. We don't say the patient has thumb metastasis. So we don't say the patient has finger metastasis. We have say the patient has a soft tissue metastasis or bone metastasis or skin metastasis. We don't say it's thumb metastasis. So it's not really to other parts of the body. Okay, so any questions for today practical? Everyone can't wait to go back. Please return your post what? Sitting photograph. And please sign your attendance